Our approach to transplant-eligible patients historically has been triplet therapy with bortezomib, len, dex, or RVD, VRD. And we really didn't have phase 3 data for that, but the SWOG study showed that triplet therapy was better than doublet, although that was for patients without the intent to transplant. And so now the question is, can we do better than that? We know that from several studies that the best partner for PIs are probably lenalidomide as opposed to cyclophosphamide. But the new question coming up is, are 4 drugs better than 3? And we have 2 versions of this question being answered. One on the European side, which was Cassiopeia study, bortezomib, thalidomide, and dex plus or minus daratumumab. And this study showed that not only was the primary endpoint of stringent CR improved from 20% in the control arm VTD to 29% with the addition of DARA, but also, interestingly, with only a relatively short follow-up of 18 months, there was a significant improvement in progression-free survival with the addition of DARA. So I think that's really great news, and it supports what we all think, that DARA is a really efficacious drug, and it improves efficacy with minimal additional toxicity. There was slight decrease in stem cell yield and more need of plerixafor, but overall, I think the PFS results and the stringent CR results are very compelling. The other study that was also recently released, the press release, we don't yet have the raw data, is the Griffin study, where patients in the US were randomized to RVD plus or minus DARA. And in this study, we saw again that the rates of stringent CR were improved, the rates of MRD negativity were improved, so also supporting the addition of DARA frontline. Of course, we don't have the details of stem cell collection, and so those data are still ongoing. And so I think this shed some light that perhaps the future might be quad therapy. In terms of consolidation with transplant, the IFM study still speaks for itself with a higher PFS relative to non-transplant.